Good evening. As Dean of the College of Medicine, I'd like to welcome you all to the third annual Vito Ambastiani, MD, class of '85, and George DeSalvo lecture on LGBTQ health equity. And tell you that, I guess, a little bit about the lecture. To our knowledge, this is the first endowed lectureship in this area at a medical school in the United States. And the purpose of it is to help us as individuals and as a college be more culturally competent delivering healthcare specifically to the LGBTQ populations. Vito and George, who endowed the lectureship very generously and very quickly, it was one of the quickest responses I've had to a funding request in my time here. Are sorry they couldn't be here today. They've been here at the other lectures, but they're pretty tied up in their roles in healthcare in Los Angeles, where Vito is a very busy urologic surgeon and was just appointed 6 months ago or so as secretary of the California Department of Veterans Affairs. And George, his partner, is the chief financial officer for all of Kaiser Permanente in Los Angeles County, which is a huge number of population, I think 18 or 20 facility hospitals. So they're sorry they couldn't be here, but they're doing good work where they are. Tonight our speaker is Dr. Macedon, who is Director of Education and Training at the Fenway Institute, which is part a multidisciplinary center of Fenway Health, which has been delivering caring for these populations for about 45 years. So it's a real long-standing, with deep roots organization, and Dr. Macedon himself has decades of experience in the field as well. So I'm very interested to hear what he's got to tell us about how we could do a better job. He's certainly been on the front lines for a very long time. And to give you a little better introduction to Dr. Macedon, Margaret Tando, our Associate Dean for Diversity and Inclusion, will fill you in.
Good evening, everybody, and thank you for coming tonight. I want to say a special thank you to Dr. Macedon for accepting our invitation and being here tonight. I also want to thank Tiffany and the staff in the Dean's office for helping us. Tiffany Delaney and Dr. Michael Upton for helping us get this lecture done tonight. Dr. Harvey J. Macedon, MD, FACP. Dr. Macedon is the Director of Education and Training Programs at the Fenway Institute and a professor of medicine at Harvard Medical School. He teaches about how to improve access to quality care for lesbian, gay, bisexual, and transgender people in healthcare settings around the country. He directs the National LGBT Health Education Center, which is a HRSA-funded cooperative agreement to improve the health care of LGBT people in community health centers, and the National Center for Innovation in HIV Care, also funded by HRSA, to help improve organizational sustainability and service models to better address the continuum of care. He is the lead editor of the Fenway Guide to LGBT Health, published by the American College of Physicians. In addition to writing numerous articles and chapters related to LGBT health, he served on the advisory committee to the Institute of Medicine of the U.S. National Academy of Sciences in preparation of one of the a big report on the health of LGBT people, building a foundation for better understanding, and that was published in March 2011. He started the first primary care-based HIV program in an academic center at Beth Israel Hospital in Boston in 1984, and has been deeply involved in issues related to models of care for people with HIV, primary care for people with HIV and AIDS, and HIV prevention, and teaching clinicians about sexual health. So this evening, we're very honored to have you here, Dr. Macadon, and everybody, please join me in welcoming Dr. Macadon.
Well, hi, everybody. I think you've probably seen enough of me, so we can probably move on. And really what I'm here to talk about tonight is sort of achieving equity for LGBT people in healthcare. And I told the students who I met with just before this that I have too many slides, but some interesting issues, and I'll try and go through them quickly so we have time for talking at the end. Just so you know, this is where I work. The Fenway Institute is at Fenway Health, which is a community health center funded by the federal government. We were started by a group of students, actually, from Northeastern in 1971 as a free clinic. And it grew, particularly with the HIV epidemic. And when I first went there to interview to be on the board in 1984 or 5, it was in a 1,800 square foot basement of an apartment building in the Fenway neighborhood near the Berklee School of Music. There were 2 doctors, a physician assistant, and, you know, it was where people started coming for STI treatment and HIV treatment before we even knew what we were doing. And now this is our main site in the Fenway neighborhood on the other side of the Fenway. If you go up to the top floor of this building and look out the window, you look down into Fenway Park. So this neighborhood has changed a lot. Since we moved there 7 years ago. We have an integrated primary care model that includes HIV services and transgender health, and we have about 2,000 transgender patients who get their primary care at Fenway, and about 2,400 or so people with HIV. The Fenway Institute, where I work, does research, education, and policy, so it's kind of an academic institution. And the Education and Training Center does tech training and technical assistance programs. We do programs like this, Grand Rounds. We have a lot of online learning. This is a photograph of an interesting kind of educational modality that's being used around the country called ECHO. And ECHO's been used to teach a lot in different parts of the country. It was started by Dr. Aurora at the University of New Mexico so that people could learn about treating hepatitis C, so they didn't all have to come into the university, that people could be treated in the community. And this is the second time it's been used to look at a population. So we have an LGBT ECHO, and now we just started, 2 months ago, we started this trans ECHO, where this is a group that's at Fenway, and we, through Zoom technology, we engage with 24 health centers around the country who present cases and discuss them with each other and among ourselves, and we have faculty who are experts in the field who really talk to them. So this is something new that we're doing, and we have a lot of resources and publications that we have on our website, so I'll invite you to take a look at that. That's www.lgbthealtheducation.org. So why programs for LGBT people? The dean mentioned that I was involved in this Institute of Medicine study on the right, the health of lesbian, gay, bisexual, and transgender people, that came out in 2011, and Healthy People 2020. For the first time, the Healthy People series included LGBT people as an underserved population that experienced health disparities. And so I think these 2 publications, which both came out about the same time, really led to a lot more interest in this. And in fact, the NIH now has included sexual and gender minorities as populations that are eligible for grants looking at disparities in healthcare. And so I think there has been a lot of change. I hope the momentum continues. But it's really led to also a lot of educational work, and that's what we've been involved in. So I think the very first piece is to realize that LGBT people, are largely invisible unless we ask them about their sexual orientation and gender identity. And I think one of the things we have to talk about is how well we do that in healthcare. But they're invisible but still experience stigma because of the way they interact with people, what they hear people say, what they don't hear people say, and what doesn't get discussed when they kind of talk about themselves in the exam room. My own experience was that I was 40. I decided to see a primary care doctor for the first time. I wanted him to tell me to get HIV tested, so I decided I'd finally tell my doctor that I was gay. I told him I was gay, and he never mentioned it again. And the rest of the session, I never went back to him. So I think that's kind of a kind of telling story that happens to lots of people about why they don't continue in healthcare. And it's something that we have to do something about to create a welcoming and inclusive environment. So stigma and discrimination have an impact on health in different ways, through interpersonal discussions like I may have had with my doctor, through structural issues such as, barriers to insurance, barriers to accessing care. And those have an impact on individuals, which lead to stress, anxiety, depression, and then ultimately health disparities or inequities. And so just a little bit about this. Interpersonal stigma, unfortunately, is often too common in healthcare settings, where people don't communicate well, people don't know about use of pronouns in the appropriate way, patients get offended or feel like kind of rejected and then don't come back for care. And so that's something that we can do something about easily. But people also experience stigma and discrimination out in the world. Kids get bullied. People, on a national scale now, we're seeing people getting, discussed in a way that, clearly has an impact on individuals. I can't tell you the number of transgender people I know who are terrified about what's going to happen in terms of their ability to live their lives, continue to have jobs, and access health care. And so we have to be thinking about that because some of that's going to fall on us to be able to take care of people and make them feel better and be responsive to their needs. So then there's structural stigma. So structural stigma are things where institutions or private or government institutions either intentionally or unintentionally restrict kind of access to care or access to sort of feeling equal about themselves. So the North Carolina kind of bathroom legislation, which restricts what gender can use which bathroom, is something that is clearly meant to, I don't know what it's meant to do, but it certainly has a very negative impact on people in terms of the way they feel. These are actually our new bathroom signs at Fenway. And we've had an evolution at Fenway from kind of unisex bathrooms to gender neutral bathrooms to now all gender bathrooms. And so terminology changes and it's hard to keep up. But we have to kind of think thoughtfully about these kinds of things. But when you think about it, there's lots of intentional kind of things, and then there's unintentional things, like some of the forms. If you go back and look at your hospital's forms, I'm wondering how many of them would say things like, what's your husband's name, or what's your wife's name, or what, instead of, what's your partner's name, or what's your mother and father's name instead of what are your parents' names. Things like that can also make a difference for individuals. And so we have to sort of go back and look at that. I found that out the hard way when I went to make I went to make an eye doctor's appointment at Beth Israel. And the call center said, what's your mother's name and what's your father's name? This was a year ago. So I said, well, why don't you just ask me what my parents' names are? And she said, that's really a good idea. She said, but I just work in the call center. I can't change, I can't change what I say. So I wrote a letter to the hospital, which I used to work at, and as a result, about 150 forms got sent to my office. And so I went through all these forms, and then I found like 10 things that were common to all the forms in different ways, but things like what I just talked about, but then other things like, list of surgeries, what surgeries have you had? And you'll be going through a list, tonsillectomy, blah, 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 appendectomy, and then it'll say for women only, hysterectomy, oophorectomy. And I said, well, we can't say that anymore. What about a transgender man? So now they've changed it, and they just have a list of surgical things. So you have to go back and look at things, because all of our organizations are built on legacy systems that have existed for years and years and years. And even if you buy a new EHR, it can carry some of those legacy kind of terms with it. So it's important that we go back and think about those things if we're really going to make a difference and remove the kind of structural barriers that kind of interfere with people feeling really comfortable getting the kind of care they need. Because when people actually experience stigma, it affects individuals in a very personal way. These are 2 transgender adolescents who committed suicide in the last year. And the woman on the left left a note saying that she hoped that by doing that her parents and her church would learn that about the impact of her having felt rejected by both. And so I think this can be, take on a very serious note with people that goes beyond just health inequities. But there are too many transgender youth who commit suicide, and a lot of this is very preventable. And so I think we have to be thinking about what we can do to make a difference. There's also been a number of studies about the effects of stigma on health. Mark Hetzenbuehler from the Columbia School of Health has talked about how people who have internalized homophobia or experience discrimination engage in more HIV risk behavior. And then a colleague of mine, Sari Reisner, did a study of over 2,500 trans masculine people and showed that just the anticipation of stigma or the having experienced stigma in healthcare resulted in a 40% increase in delaying needed urgent or preventive healthcare. So I think, again, we can make a difference by thinking these things through and educating ourselves in ways that make a difference, but we have to. So some of the disparities that we know about are fairly well documented. There's some that I think we need to learn more about, but begin in childhood and adolescence and continue on through adulthood. So youth, LGBT youth, are more likely to attempt suicide, more likely to be homeless. In some studies, up to 40% of homeless youth are LGBT or T. Have a higher risk of HIV or STDs, particularly young black men who have sex with men. LGBT populations have the highest rates of tobacco, alcohol, and other drug use. Lesbians and bisexual women have been shown to be less likely to get preventive services for cancer, both mammography and pap smears. Focusing in on transgender people, and not from Healthy People 2020, but from the National Transgender Discrimination Survey, 41% had a lifetime suicide attempt. 41% is compared to 5.6 to 14% of all U.S. adults. That's a huge difference. 26% use drugs and alcohol to cope with discrimination. 30% smoke daily compared to 20% of other U.S. adults. And 48%, again, postponed or avoided medical care when sick or injured because of cost, and 28% because of perceived discrimination. So again, these are the kinds of things that really do make a difference. And then we think about the elderly. Elderly individuals face additional barriers to health because of isolation, fewer family supports, and a lack of social and support services. And because they avoid health care for many reasons, they often experience more disabling conditions. So again, I think we have to, we have a lot of work that we know we need to do, and I think that there are ways that we can begin to make a difference for people and need to think about it. I wanted to spend a few minutes going over some concepts so that we're all sort of in the same page, although from meeting with a group of students before this, I feel like you're way ahead of me, and so I don't know where everybody else stands. But I think that the most important thing is that we understand the difference between gender identity and sexual orientation. And there's lots of words that people use to describe both of these, and I'm not going to get into all of them, but I will get into some. But we have to realize that terminology changes quickly, and we have to keep up with it if we're going to have some credibility with people. First, I just wanted to start with sex and gender. They're terms that are often used synonymously, but they're increasingly kind of being, they're diverging. Sex really relates more to one's biology, their anatomy, their genes. It's male or female, and then sometimes I think it's important that we realize that some people are born with intersex conditions. Whether that's a sex or not, or a condition, you know, I don't know, because I think there's a lot of literature that might describe it in different ways, but I think it's important that we recognize it. Whereas gender refers to attitudes, feelings, and behaviors that a given culture associates with somebody's sex. Within individuals, there's an increasingly expansive sense of identity that definitely comes from within. So we can think of cisgender, not transgender people, as well as transgender people, and they can all identify as men or women, and a lot of transgender people don't say they're transgender, they just identify as men or women and never use the transgender term at all. So it can make it that's why it's important that, as I'll explain later, that we understand what someone's sex assigned at birth is and what their gender identity is. People can be gender non-binary, neither male nor female, and use masculine or feminine as a way of describing themselves as opposed to male or female. And sometimes people are gender non-conforming. They're just not conforming with the sex they were assigned at birth, and they leave it at that. And so, again, these are all terms that, you know, people use and that we hear, and we have to learn more about them. So India recognizes transgender people as a third gender. And in India, there's a huge population of people, and they vary in different parts of India, but the Hijras in the area where I used to work in India were, you know, a large population that used to be actually kind of revered, and now they're not quite as revered as they used to be. But India gives them an opportunity to kind of acknowledge that that is the way they identify themselves on their birth certificate. And then just last week, Nevada passed the most progressive birth certificate gender change policy in the nation by allowing people to kind of, without a doctor's letter, state their gender and then verify that just with a letter from a close friend stating that that was their gender. And I think the one thing that I think we need to be cautious about is that we not conflate gender and sex. So that someone can have their gender identified on their birth certificate, but it shouldn't be in place of what their assigned sex at birth was, because that's something that clinicians need to know in order to take good care of them. And we can talk more about that, but I think that in some places, the two are used almost simultaneously, and I think we're really meaning to say two different things. And so that's something that I would just keep in mind, and you know, if you have feelings about it, we can discuss that. But I think the main thing is that sexual orientation and gender identity is not the same. All of us have one of each. They're not relational, but everyone in the room has one of each. And terminology is going to vary. It changes with time, and it may change in an individual over time. And so, yet, we have to be aware of these. Then we get into gender identity, gender expression, and gender roles. So gender identity is a person's internal sense of their gender, whether they consider themselves male, female, both, or neither. Gender expression is more how does one present themselves through their behavior, mannerisms, speech, dress, and hairstyles. And, you know, they're not, again, related. So someone's gender expression may or may not correlate with their gender identity. And someone's gender expression doesn't necessarily suggest that someone is anything. I mean, you can be a straight person who has a more masculine or more feminine gender expression. People are different. Gender role is something that's more of a social construct, which is a set of roles, expectations, and behavior that are assigned to males and female by society. And we're trying to break those down, but it's hard. And yet, I think they still exist. And I think they exist pretty much in the context of the binary, so that when you begin to break down the gender binary, so beyond male and female, those gender roles also begin to come apart. And that's something that we have to be thinking about. So this is definitely a gender expansive era where people are thinking more widely about gender and well beyond just male and female. So we just published this at Fenway called Providing Affirmative Care for Patients with Non-Binary Gender Identities. It was written by a college student who worked with us last summer. But it's really a way of explaining to clinicians that there are going to be people who aren't going to be able to say whether they're man or woman, but they're going to try and describe something different. And we felt like clinicians needed to understand that so that they could relate more to their patients. And this was partly supported by a study that was done by a colleague of mine at Fenway, where they studied 452 transgender adults in Massachusetts. 40.9% of respondents described themselves as having a non-binary gender identity. So that's a pretty large number. And I think that we're seeing gender non-binary people with increasing frequency who use different terminology but don't identify as male or female. And so again, I think this is one of the changes that we kind of need to begin to understand more, and needs to be something that not just students but faculty and all people who are seeing patients kind of understand. The basic things in terms of understanding transgender issues that I sort of like to summarize with is that gender identity is not congruent with assigned sex at birth for people who are transgender or gender nonconforming. There's different terminology, whether it's transgender woman or trans woman or male to female or transgender man, trans man, female to male. Then there's people who are non-binary who might use the term gender queer or transmasculine and transfeminine. But there's no question that gender identity is increasingly being seen as on a spectrum, if not beyond a spectrum, in terms of having more dimensions than a single spectrum could really illustrate. Then we go from gender identity to sexual orientation, which is something that I think we're more intrinsically familiar with. Sexual orientation is how a person identifies their physical and emotional attraction to others. I think that probably desire is one of the things that gets the least attention when you go to the doctor, but maybe the most important thing is to be able to give someone an opportunity to talk about desires that they've never acted on, but may be thinking about, and may make a huge difference in people's lives if we could have the time to spend talking about that. And then there's behavior, which we probably do talk about because we know that HIV is related to behavior and STIs are related to behavior. So we ask about whether men have sex with men or men have sex with men or women, or in the kind of non-binary world, we may ask questions now like, who do you have sex with? And let people just tell us, instead of sort of prescribing men, women, or both, because there's more options than just men, women, or both. And I think we have to recognize that. And then identity could be straight, gay, lesbian, bisexual, queer, or other. And there's lots of other terms that people use that people may respond with. I was telling the students before about, I was asked to give a talk about health disparities among people who identified as asexual. And, there are people who identify as asexual. I just said that I didn't know, there wasn't enough data about what health disparities they experience, but it's definitely an important topic. And certainly we haven't learned enough about bisexuality so that people can feel comfortable talking about it. So again, I think all of these kind of require a little bit more investigation, but certainly familiarity and comfort with talking to people about these issues is the first step. I think probably most importantly is that sexual orientation and gender identity are not the only things that define individuals. And this is nice that this is happening under the sponsorship of the Diversity Office, because diversity is complex. It's not just LGBT, it's not just sexual orientation and gender identity, it's race, it's ethnicity, it's socioeconomics. So the concept of intersectionality comes up. And intersectionality is that an individual has multiple different cultural inputs, and how those come together in a given individual are going to change from individual to individual. And so that's an important thing for us to recognize, that intersectionality really is based on a number of factors. Intersectionality is the study of intersections between forms or systems of oppression, domination, or discrimination. An example is black feminism, which argues that the experience of being a black woman cannot be understood in terms of being black and of being a woman, considered independently, but must include the interactions which frequently reinforce each other. And so I think that these things, this could become more complicated. That's a kind of fairly succinct way of thinking about it. And then from a clinical perspective, a gay man has to deal with homophobia, a black man has to deal with racism. But a black gay man has to deal with homophobia and racism, often at the same time. And it's often the case that he'll face racism in the LGBT community and homophobia in the black community. And so sometimes when we're talking to people, we have to kind of understand these things if we're really going to help them kind of figure out how they can be comfortable and go out in the world and live, kind of healthy, productive lives, and also stay healthy. So I think that, the concept of intersectionality brings a lot of the work we do in diversity and inclusion together, and makes us realize that we can't look at LGBT in a vacuum, but has to be looked at in the context of the greater diversity lens. I think finally I just wanted to end this part of the talk by saying that LGBT people have an incredible vulnerability to poverty. African American children in gay male households have the highest poverty rate, over 50%, of any children of any household type. And children living in lesbian families have a similarly high, but slightly less high, poverty rate. And then transgender respondents to the National Transgender Discrimination Survey that was done in 2011 were 4 times more likely than the general population to have a household income of less than $10,000. So when you think about being transgender, living on a household income of less than $10,000, it's kind of hard to get by. And so, when we wonder why people might engage in, let's say, transactional sex, it isn't necessarily just a choice. It's like a reality of what people need to do to deal with the structural issues in their lives. Because they're discriminated against, they can't get jobs, and so people have to get by. And so, I think we have to kind of understand these things and recognize these things when we're seeing patients and when we're kind of thinking about what leads people to do certain things in our minds. So now, having gone through disparities and sort of basic terminology, what can we do to make a difference? So I'm going to talk a bit about ending invisibility, a bit about clinical education and communications, and then a bit about the environment. So I would just ask you, how often have clinicians asked you when you've gone to the primary care physician, how many of you have been asked about your sexual health or your sexual orientation or gender identity? Raise your hands. Well, it looks like more than in most groups, but I'd still say it's 50%. And then you have to think about when you're seeing a patient, and I know most of you are just learning, and some of you are already doing it. Michael's done it. how many of you really routinely ask these questions? Hopefully you're not asking your patients this question. But anyway, I think we have to start there and realize that, how infrequent it is that we actually talk to people about that. So we have to talk about what we need to do a better job getting to know patients in clinical settings. I'm stuck here. What do I do? Something happened. There we go. Okay. So in this one study of proportion of physicians discussing topics with HIV-positive patients, 84% talked about adherence to antiretroviral therapy, but only 14% talked about HIV transmission or risk reduction. So you can see the difference between talking about a medical topic and talking about something that, very few people talk about, which are the softer things that people do regarding their behavior, which led the Institute of Medicine to write, ironically, it may require greater intimacy to discuss sex than to engage in it. So, we've done these brochures on taking routine histories of sexual health. We've kind of talked about this, but no matter what, and I think it's important that we go over these things and sort of try and make these things routine, make no assumptions. Doctors are not great about talking about sex and taking a sexual history. We don't have the time to do it. We're not taught to do it. It just doesn't happen. So the Institute of Medicine actually came out with a report, the report that we just talked about in 2011, where they recommended that data on sexual orientation and gender identity should be collected in electronic health records. And a lot of places around the country are. I thought when I was on the committee, when we made this recommendation, I thought that I can't believe anyone's ever going to do that. But now every single health center in this country is required to do that this year. And a lot of major medical centers are doing the same. And so that's the only way we're going to get to know about people's sexual orientation and gender identity. And I'm going to talk a little bit about this, about collecting what we call SOGI data in electronic health records. And this is a sort of summary of what we know about this that we put together at the Fenway that's on our website. But I think it's important for clinicians so that they need to learn about LGBT health in order to respond to this information, for non-clinical staff to know how to engage with people and communicate with people, and then for patients to know what they should be talking to their clinicians about. So we actually developed this brochure where we provide information to patients about new sexual orientation and gender identity questions for health centers that are actually doing it. And some hospitals and health centers have adopted these. But we feel like, it would be important to give out information about this. So it's a 2-page brochure that you can download off of our website. I think the process is fairly clear. Different people have different approaches. You can collect data if you have a patient portal. Do you have a patient portal here? Okay, so you could collect the data from home before someone came in to their appointment. You could collect it at registration through a tablet or a kiosk or on a piece of paper, so it doesn't have to be a conversation with a receptionist, and then have someone input the data into the electronic health record. And then, I think probably the least successful has been asking providers to ask this information because they don't have the time to do it and for all the reasons we discussed. But they can fill in the blank. So if someone leaves a blank, you can say, oh, I see you left this blank. What were you thinking? Or what, is there something you want to talk about? And so there's, a way of doing it. But I do think that kind of figuring out how to do this as part of demographics is probably going to be the best solution. And that's what we do at the Fenway. So at the Fenway, this is part of the paper demographic form. And question 7 is, do you think of yourself as lesbian, gay, or homosexual, straight or heterosexual, bisexual, something else, or don't know? And more people answer this question than answer question 1 about their annual income. So I do, and we've actually studied this in places like in health centers across the country, including a group in South Carolina, in rural South Carolina, where like 80% of people said it was important to let your doctors know about your sexual orientation and your gender identity. Now, whether the people filling out those forms knew what that was, I don't know. But we got really great results from all over the country. In terms of gender identity, it's a little more complicated because you want to know about someone's current gender identity and look at the terms that we just talked about. But you still need to know what sex someone was assigned at birth because you need to know what their basic underlying anatomy is. And so we do need to know whether someone was assigned male or female at birth. And then in addition, I suggest that we ask, what name do you use and what are your pronouns? And I'll talk more about pronouns in a bit. But I think just to allow people throughout the practice to have communication, we need to know what name someone uses, if it's different from what was their legal name on their chart, and what pronouns they use if they have chosen pronouns which are different than those which might be expected or used in the past. So again, we think we should gather this information at registration. After we do this, though, we have to think about what do we do to make this work. And part of it is looking at data integrity and quality. Are people filling out the forms? Do we have appropriate decision support? And are we looking at quality and patient satisfaction? And are we educating staff so that they know how to communicate with people in an appropriate way once we gather this information? So data reporting and quality checks can be very complicated, but it really means going through each chart and making sure that the information's filled out, it's consistent, it's not, being filled in by I remember when we started asking about race and ethnicity, the registration person would look up at somebody and say, they'd fill out, they wouldn't want to ask the question, so they'd fill it out by looking at somebody. You can't do that with sexual orientation and gender identity, although I think some people try. But we have to make sure that the data is appropriately collected. And then decision support is really important. So here's a screenshot of a decision support form for a 50 to 64-year-old female, where it talks about making sure that they have a tetanus booster every 10 years, that their blood pressure is taken every 24 months, their cholesterol is done every 5 years, their mammogram every 24 months, their breast palpation every 24 months. Obviously, these things change with time. But we're used to having this for all kinds of patients, but we don't have it specific for LGBT people and particularly transgender people. So there are some resources to develop decision support guidelines. One is the website for the Center of Excellence for Transgender Health from UCSF. And the U.S. Preventive Services Task Force does give us some information. And I just wanted to go through two little examples because I'm sort of trying to develop these little things on my own. And I told the students before that this is a little test part of the thing. Not test you, but test me. But like we're trying to figure out how do we do this. So if you take somebody whose gender identity is male, sex assigned at birth is male, sexual orientation is gay, age is 24, only surgery is a torn meniscus, their meds are marijuana and occasional recreational drugs, what alerts would you put down for that person? So I put down we'd need a sexual history. We'd need to check his HIV probably more frequently than the one time recommended by the U.S. Preventive Services Task Force, STIs more frequently, and an HPV vaccine. Anything else? I didn't have anything else. That's all I could think of. For transgender people, we need to not only think about this, but we need to know what their anatomy is because some people have had surgery. So as I said to the group before, a transgender woman may still have a penis, may not have had any genital surgery. And you want to know that before you are doing your exam. So doing an anatomical inventory is something that's very important. And you want to know like what's happened to these organs over time. So if you were developing something like this for someone whose gender identity is male but whose sex assigned at birth was female and identifies as bisexual in terms of sexual orientation at 56 years of age, the only surgery this person has had is a breast reduction mammoplasty, and the only medication this person takes is testosterone. So my alert in this was sexual health was one thing. And then I went to the U.S. Preventive Services Task Force and looked at what would be recommended for a 56-year-old woman in this category, and looked at things that were relevant, and some of these things would be relevant. Both A and B recommendations are the things that are paid for by the Affordable Care Act. May it continue to live. But then we get to sexual history. This person's also had voice surgery. And so then we want to know about this person notably was assigned female sex at birth, has had only a breast reduction mammoplasty, hasn't had any genital surgery, but could engage in, let's say, anal sex. And so we don't know that, but we want to know about HIV and STIs. I think I did it again. Oh. There. Pap smear and HPV cytology, testosterone levels with a reference standard that isn't related to females, but the person should know that this is a transgender male who's taking testosterone so that you get the right reference level. Pregnancy plans. Did anyone, this woman's 56. I mean, this transgender man is 56, so he may be older than wanting to have children, but he still may want to have children, so you need to talk about pregnancy plans before starting someone on testosterone, or tell them to stop it so that they don't interfere with pregnancy. And then breast screening, because even though he's had a breast reduction mammoplasty, he still may have residual breast tissue and be at risk for breast cancer. And so some kind of screening is important. So those are the kinds of things we need to think through when we're thinking through what are the recommendations for people, in different circumstances. And there's lots of categories. There's lots of different cells to fill out, and we have to think that through. And then we have to look at quality and satisfaction with care, so that, for example, we want to compare people, whether they had an HIV screen completed, compare different kinds of people, lesbian, gay, with bisexual, straight, heterosexual people, to know whether or not they've had the HIV screening that's recommended by the U.S. Preventive Services Task Force, and see whether there are any disparities. Because, our goal is to eliminate disparities. And knowing this information about sexual orientation and gender identity will allow us to learn that. So I think that's something that I think would be a great project for a student to be thinking about decision support once we know about sexual orientation and gender identity, because no one's done this yet. Not one electronic health record has done anything about this. And it's something that's just sort of waiting to be done. And then think about, what do we need to educate ourselves about? So I'm just going to pick 3 quick things: HIV prevention, transgender health, and effective communications. So we have to think about how we improve HIV prevention and care for both men who have sex with men and transgender people. The CDC data from 2014 showed that 70% of people infected with HIV in that year were men who had sex with men. And I think we should just ask ourselves, in this institution, what is done routinely to reduce the incidence of HIV. So for example, if one of you went now to the computer and did a search and said, you want to look at all people between the ages of 15 and 65, knowing that the U.S. Preventive Services Task Force recommends that everybody has to have one HIV test in that age group, what percentage of people do you think would find have had one HIV test? So make HIV screening routine is really a critical piece, because we don't want people walking around who don't know their HIV status, who may be HIV infected or maybe not HIV infected, where there are things to do about it. Because for people who are infected, they should be on antiretroviral therapy and put on antiretroviral therapy right away. That's another thing you could tell if you know who's HIV infected from just, again, a simple search in your computer. And then for people who are HIV negative, then the question is, how many people, we've talked to people about using condoms, we've talked to people about behavior change. It hasn't made a dent in the number of people who have HIV. We still have the same number in this country now every year. So we have to start thinking about doing things like using pre-exposure prophylaxis, which is taking 1 pill a day of a medication that's a combination of 2 antiretroviral pills. It's no more complicated than taking an aspirin. There are really no more side effects than taking an aspirin, but doctors are reluctant to prescribe it. And so we can make a big dent in the HIV epidemic, I think, by looking at these 3 things and looking at what each of our institutions is doing to systematically make sure that we deal with all of our patients in an appropriate way to reduce the incidence of HIV. And I don't mean to be oversimplifying things, but I think that it's much more simple than people really think it is. And so I would think that these are things that we should all be considering. I wanted to turn now to some care related to transgender people that goes beyond hormones or surgery, but is basic preventive health care. I already suggested that transgender men might need, who've had breast reduction, still need breast screening. But here's a case of a 45-year-old man who came in with pain and on x-ray what appeared to be metastases from an unknown cancer. Evaluation showed that he had developed metastatic breast cancer. No one told him he needed breast cancer screening, even though his mother and sister both had had breast cancer. So he was probably genetically at high risk for breast cancer. And this, is something that, again, we don't think about. A less serious but nevertheless significant issue is this 59-year-old woman who was also transgender who came in for head and neck surgery and developed postoperative fever, and the source was her prostate gland. But no one knew she had a prostate gland because no one ever took her the history to find out that she was transgender. And all transgender women have a prostate gland if you think about it. It's never removed. It's always there. But people stop thinking about it because they don't think about that basic inventory that we talked about. And we don't have these kinds of things built into the reminders that we're used to getting when we're seeing a 50-year-old man about doing a prostate exam. So again, I think we have to be thinking about these kinds of things. And then, as I mentioned earlier, transgender men get pregnant. Have there been any deliveries here at this hospital? Transgender men delivering babies? Because I was at Mount Auburn Hospital in Cambridge and they'd had 3. And I know at Fenway we've had 2 men who've had pregnancies. That we don't deliver babies at the health center, but we send them up the street to Beth Israel Deaconess. But we ended up doing a training for the staff there. But the main thing is that, we have to think about what we need to do. So if someone comes in and wants and is talking about being transgender, it's important that we talk to them about wanting to have a family and what that means to them. Counseling them on perhaps banking embryos, eggs, and sperm before they start hormones. Because a lot of the men who actually conceived and have had children have done it on testosterone. A lot of people think that testosterone is a birth control pill, but it isn't. And so again, I think we have to be thinking about this kind of basic education if someone comes to us talking about being transgender. But we also have to think about other things like alternate methods like adoption, surrogacy, and IVF. For transgender people and for all LGBT people. And so we need to be thinking about teaching primary care providers this, because it's not just the OBGYN who, kind of faces this situation. And I think the most important thing is the nurses, the staff on the OB unit. All these people need to be taught about the kind of issues we're going to talk about in a second about communication and providing affirmative care throughout someone's pregnancy, because it really can make a difference. So we've actually developed this, again, another little kind of handout called Pathways to Parenthood for LGBT People, which really talk about some of the challenges that people face. And different state laws are different about surrogacy and adoption and things like that. So that, and you know, it's important for clinicians to know about this. So this is a little way of learning about that. And again, this is on our website. So I've been talking the whole time about the importance of communications, and I think the main thing is it has to begin with training people at the front desk. And this is a little bit of a fake thing, because the only picture of a front desk that I could find is this, which is a veterinary office. But I thought it looked close enough to a health center that I could use it. So there's no one there. I don't see anyone carrying their dog. But you know, when you think about it, you have a lot of interactions with people in the waiting area. And I can tell you that when we're called about problems, let's say with transgender patients, it's usually because they happen in the waiting area, where people are refused care, where people won't use someone's pronouns, even though they tell them that these are the pronouns. And that's why the Attorney General came to us about problems in 2 hospitals in Massachusetts. And so I think that, you know, these kinds of things are more significant than we think. And I've had 5 years to hear about complaints, and I can say that 90% of the complaints are about things that happen in the waiting area. I think it's important that we recognize that, you know, when you see someone, you're not the first healthcare staff person an LGBT person has met. Many have had a history of problems in the past and might overreact. It's important not to personalize your reaction, but sort of apologize and try and create a constructive dialogue. And then there's ways that we can kind of train people, and these are just some examples. But you can't assume someone's gender or sexual orientation based on how they look or sound. And to avoid assuming anything, instead of saying, "How may I help you, sir?" say, "How may I help you?" Or instead of "He's here for his appointment," say, "The patient is in the waiting room." And instead of "Do you have a wife?" as I said before, "Are you in a relationship?" And instead of "What are your mother and father's names?" "What is your parents' name?" or "What is your parents' or guardian's name?" Because not everybody has 2 parents. So again, these are the kinds of things that make a difference. Pronouns, can exist. You know, you could get a list of 50. I actually was at a health center where they were developing their EHR, and they were putting 25 pronouns in their EHR. And I said, I think they should cut it out, because I thought it was probably going to be too many for people to kind of respond to in a reasonable way. But there are people use a range of pronouns, including she pronouns, he pronouns, as well as less common pronouns, as very commonly used for non-binary people as they, them, and theirs. And then others like Z, here, and here's are also sort of fairly commonly used. And so we have to be prepared to hear people say that and give them an opportunity to use it, but also be familiar enough with it so that we can say something like, you know, and a lot of people have a hard time with this. So when someone says their pronoun is they have a hard time using they for an individual. But we have to practice. They are in the waiting area. The doctor is ready to see them. That chart is theirs. If you think about it, they may be a better pronoun to use for everybody than he or she. And so, you know, these are the kinds of things that we have to kind of be thinking about. At Fenway, the staff have buttons that say my pronouns are, and we have 4 options. We have he options, she options, they options, and ask me option. It's not that everybody needs to wear them, but it kind of gets people thinking about, well, we should talk about this. And so, you know, it's kind of one of the things that we've done to try and improve our ability to communicate well with people and to show people that we're actually interested in hearing from them. Keeping up with terminology is very important. It's very important that we don't use disrespectful language, that we don't gossip. If when gossip happens, someone invariably hears it. It may not be a patient, it could be a colleague, it could be a student. Students often report what they hear the attending say on rounds, and it's shocking. And then they don't have anyone to go to about it because the attending is the person who's grading them. And so it creates all kinds of issues. So then they go to your office and talk to you about it. But then, you know, I'm almost embarrassed to do this, and I keep wanting to take this last bullet off the slides. But like telling people about not saying things like, you look great, you look like a real woman or a real man, seems shocking to me, like seem almost like it could never happen. But like everyone in my office said, they hear these things all the time. Or, you look so pretty, I can't believe you're a lesbian. I mean, you know, it's like, but, you know, I kept it on the slide because every time I want to take it off, I go to the rest of the staff and I say, can't I take these off the slide? They say, no. They said, you know, we keep hearing stuff like this. So again, we can make a difference, but we have to learn how to communicate. So, just to kind of bring this piece to a close, if you're unsure about a patient's preferred name or the pronouns they use, you can just say, I'd like to be respectful. What name and pronoun would you like me to use? If a patient's name doesn't match their insurance, you could just say, can your chart be under a different name, or what is the name on your insurance? And if you make a mistake, just apologize and say, I'm sorry, I didn't mean to be disrespectful, but don't get into an argument. I think there are so many situations that could be resolved just by a simple apology, which is true not just in healthcare, but in many ways. But I think that we need to learn this. I'm going to just close by talking about creating a welcoming and inclusive environment. So I'd say adding affirmative imagery and content to education and marketing materials can make a big difference. Think about like your choice of where you go. I don't know if people here have much choice of where they deliver a baby, but think about if you had a choice, you know, you'd go to a place that had a same-sex couple on their marketing materials or their education materials. Or if you're an older couple, you know, think about where you want to go for primary care, and go to the place that, you know, that shows that they want to take care of same-sex couples, because it can make a big difference. We developed these posters and this brochure for a health center in North Carolina that wanted to put something in every examining room so that patients would talk about being LGBT. So we had these do ask, do tell posters. We have these now on our website in English and Spanish for adults and for adolescents. And they both come with a brochure that, you know, kind of talks to patients about what they should talk to their clinicians about. So again, I think little things can make a difference, and we've gotten thousands of requests for these from places all over the country. So again, I think that you know, there's lots that can be done, and it doesn't have to cost a fortune. So what I've talked about now, I think what I've talked about is data collection, clinical education, consumer education, all put together so that we can provide patient-centered care. And our goal is not just that we provide good care for LGBT people, because I think a lot of the things that I talked about really apply to all. So our goal is really quality care for all. And at this point, I think we have time for questions. So thank you very much. I think that the reason we have that is because they're just people who actually feel very sensitive about it, and they don't want to answer it. And that's one of those things where I feel like if someone doesn't answer their assigned sex at birth, you know, that's not a discussion that could be had at registration. But if that blank is there, that's the kind of thing where a clinician could explain to somebody why it's important to know what sex, you know, what their assigned sex at birth was, or what condition existed, so that people can kind of take appropriate care of them and explain that in more detail. Yeah, so I think it's, but I think it is, yeah, I think it's very important that we know that. And I think it has to be phrased in the right way and people have to understand, why. And there is information in that kind of handout we have about sexual orientation and gender identity, about, why we ask that question. But that's why decline to answer is one of the possibilities. So wait, are you? Oh, no, no. So, all right. So I should have, no, what I said would really apply. Like, for example, we just started a family practice and we're doing pediatrics and the same issues apply. I think there's a little bit more sensitivity about asking these questions of kids routinely. And HRSA actually, so we're funded by HRSA. So HRSA has said, we're not going to require that health centers do this for people under the age of 18. At Fenway, our practice is we will ask people about gender identity once they're, we'll ask people about gender identity whenever they want to bring it up, but we'll ask people about sexual orientation once they're 13. Because we feel like kids question their gender identity beginning age. I mean, I spent an hour and a half talking to a mother whose 2-year-old daughter refused to get toilet trained unless she could wear boys' underpants. And now, kind of 8 years later, the mother's, at that point, the mother refused to take the kid to the gender clinic at Children's Hospital. Now the mother's the biggest advocate for, kind of gender education in schools and healthcare. So no, I wouldn't separate it. I'm an internist, so I probably have a little bit of bias when I write things, but the issues apply to kids in the same way they apply to adults. I think it's more complicated. We know less about the sort of trajectory of gender development in kids. But like when we do our transgender course at the Fenway, we start off with a session on gender development in kids that is taught by a pediatrician, adolescent physician who does this kind of work. And I think it's extremely important. So, I didn't mean to give that sense. And I think there's a clinic here, right? Yeah. You were about to raise your hand.
I had a question about the use that information.
Right. Well, so there's several answers to that. One is, so the issue really is around confidentiality and privacy about SOGI information. So I would say, one, I believe that electronic health records keep information more private and more confidential than paper records. You're probably, I'll say it, I'm old enough that I still remember paper charts. And I remember that after I finished seeing patients after a morning in clinic, there would be a stack of charts sitting outside my exam room that would be like 2 feet high, sitting on a table, and anyone who walked down that corridor could open any chart they wanted to and read anything they wanted to about any patient, because there was no place to put the charts. And that was true on the inpatient units, and that was true on the outpatient units. With an electronic health record, there's no paper. The information is in a computer. And anyone in in our hospital, and I think this is true of all systems, I'm sure it's true of Epic, anyone who looks up information about any patient, that name is recorded. And so you can find out anyone who looks up any piece of data. And I know that at our hospital, people were fired for looking up information about patients where they had no business looking up their information. So that's not completely reassuring because, you could still say, well, the person at the front desk may know the sister of the person who's registering and, may have a conversation. But I think that, we work in hospitals. We have a pledge to, keep what we hear confidential. That's part of what we learn as clinicians, but it's also part of what we have to teach. There's HIPAA violations. There's all kinds of things that people don't talk about because it's against the law. And so I think that the benefit of providing this information far exceeds anything else. And that, I sometimes think that the whole, I take confidentiality very seriously, But I think when people kind of feel like that's a reason not to ask this information, I feel like that's an excuse not to get into something that people just aren't comfortable with. I mean, the clinicians who originally, when we first started having these conversations, the objections to asking this information came largely from clinicians. It wasn't coming from patients. Consumers largely felt like it was important to provide this information to their clinicians. Clinicians felt like it was too sensitive to ask this information. And I just think that we just have to get over it. Well, all I can say is we talk regularly with vendors. That Epic is one of the groups that we talk with regularly. That they've said that they've kind of made the shift so that they're now willing to ask the questions as a demographic question and not just have the clinician be the one to ask the question, which was a major change for them. They said they're going to have an anatomical inventory ready by the end of this year, like by January. And in terms of decision support, we had a vague conversation about working with them to do it. We're having a conversation. There's actually a group in Oregon called Ochin. It's weird, actually. They sell Epic, but it's a different version of Epic. They're interested in working on it. There's a lot of people who are now realizing that asking these questions is good, but that they really need to have more to it. There needs to be more of the care system built into it, and it has to parallel what we do for all patients. So just the other day at Fenway, we made a list of like 15 people that we thought we would invite to a conference to convene to talk about, how do we do this? But it's really in its infancy. And I think that, I did what I showed you on a Sunday night, because I had to give a lecture and I was trying to think about what do I do. So I don't think it's that hard to think about it, but I think if we want to do it and document the evidence for each one and everything, there'll be a fair amount of work. But I think it's one of the challenges that we have to, take on. Try that. No, actually, it's funny because I had this, I used to teach Patient Doctor 1, and one of the things we would do would be take a medical student to go see one of our patients in the hospital. And I had this patient, and I'll say her name because she's long not with us, but Marguerite Hennessy. And she was this kind of wild and crazy woman who lived in the Fenway neighborhood when the Fenway neighborhood was kind of like filled with elderly people and the Red Sox weren't winning the pennant every year, and it was a very different place than it is now. And she had this kind of Leo, this guy who would bring her into her visits, but she would always say, "Oh, Leo's not really my boyfriend," and that. But I never took a sexual history from her. She was 90 years old. She had her, because I remember she broke her hip on her 90th birthday. Coming in the hospital, on the door that closed, she fell and she broke her hip, and she was in the hospital. And so I took this patient, this medical student, Andrew, who was going into surgery, to see her. And Andrew, and I had never taken a sexual history from her. And Andrew was a really good medical student, even though he was going into surgery. He had the little list of questions that he needed to ask, and he's going through the little questions, and he goes, now I'd like to talk to you about your sexual history. And Mrs. Hennessy, propped herself up in bed, and she just looked at him, and she said, "Now you're talking." And, it's funny. I just felt like, here, I've been such a jerk, I never would, even broach the subject with her. And she just went on and on about, boyfriends and this and that and the Leo. And I learned more in that 15 minutes than, But, I think that we are. We're afraid to sort of talk about these things because we're not taught it. And it isn't one of those things that's routine. But I think that's why the thing from North Carolina, encouraging patients to talk to their doctors and putting it in the hands, I don't like to put stuff basically make it the patient's responsibility, but the combination of the sign in the exam room and the brochure for the patient makes it pretty clear that it's okay to have the conversation. And, you know, we're training the staff at the same time we're telling patients what they should talk about. And I think that they feel like it's made a difference. So, you know, I hope that we'll see some change in that area, but I also think that asking these questions, you know, really heightens, you know, the need to do more things to train staff and things like using pronouns. And also, you know, to do what you're suggesting is we have to do a little bit more work so that we build the clinical aspects into the electronic health record that really meet the needs of the patients we're seeing. So I guess we're coming close to the end of the time, but we have time for one last question if anyone has one.
In your clinic, it looks like you ask all of your patients what their pronouns are, not just people you seem to.
Oh yeah, at Fenway we do. We ask, you know, everybody about their pronouns. HRSA is not requiring that HRSA is not requiring that health centers report pronouns as a UDS measure. They're requiring that people ask about assigned sex at birth, gender identity, and sexual orientation.
What's your opinion on that?
I think HRSA is doing a game changer by even doing what they're doing. I wish they had done more because I think, you know, it would make it even better. But the fact that like HRSA's doing this and that Medicare and Medicaid haven't done it yet is like, I mean, I actually had this conversation with someone from CMS and I was telling them, I said, you know, it's amazing, but I said, why aren't they more active? This person apparently went back to someone else, and I wasn't like arguing with them, but this one person went back and said, this guy from Fenway's like, he's like an act up. He's like rabid about asking these questions about sexual orientation and gender identity. So I feel like, you know, in our current atmosphere, if we can get this done under the radar and continue to do it, I'd be very happy. And we'll deal with pronouns, you know, by teaching, and it's natural that it's going to come up. And so people need to be prepared to do it. I do think that, like, for your EPIC here, and since the dean's sitting here, I can sort of take this opportunity. It would be very nice on the header of every page in the electronic health record to have someone's name that they want to be called and the pronoun that they use so that people can communicate appropriately with people and avoid problems. And, you know, I think that since EPIC is really making this available now. And so I think since various birds told me that the University of Vermont hasn't done much with this yet, I think it would be a good thing to do.
Actually, there's a whole team working on that. Not in here, but there's a team that's actively doing it.
They are? Oh, because someone said to me before that there had been no.
Yeah, but it's back on.
All right, well, I'm glad it's back on. So, you know, we worked with the Brigham and Women's, we worked with Mayo, we worked with a bunch of places. So if you want anyone to sort of talk to the team, happy to do it.
We're about to spend $100 million.
What?
We're about to spend $100 million the next.
I know, so they can throw in sexual orientation and gender identity. As like a little gift. And maybe pronouns. So anyway, thank you all very much. I really appreciate coming up here and being here, and I'd like to thank all the people who the thousands of people who kind of organized this, from Joanne, who isn't here tonight, and Michael. So thank you very much.